In this lecture, we will talk about nutrition care for patients who undergo bariatric surgeries. Information in this lecture comes from the nutrition care manual online. We need to be very clear that it is not a dietitian's responsibility or SOP to determine who is eligible for bariatric surgery. So it is the doctor and in certain cases, mental health professionals come together to decide. And as we mentioned previously, nutrition care for these patients should include everything we have talked about regarding obesity in general. So lifestyle, including diet modification, increased physical activity, applying behavioral therapy sessions, and weight loss pills in certain situations. So all those are still applying to these patients who are getting the surgeries. And we should pay special attention to the contents of NCP that apply only to this category of patients. Everything else applies, but there's something special for these patients. As dietitian, when we work with patients who may be eligible or on the way to get ready for the surgery, we need to be very clear and we need to document previous failed attempts to lose weight through diet and exercise. Because the surgery is more expensive for everybody involved, especially insurance company, and they really want to see that the patients have tried cheaper, less invasive interventions before, but those didn't work out. So we need to document this. And we also need to document the use of medication trying to lose weight. Right? We mentioned Xenical and Meridia, and people have to be on this medication for 4 months, still couldn't achieve reasonable weight loss. So after the first 2 points, documentation will be clear that okay, neither lifestyle change nor medication could induce successful weight loss, and the patients have a high BMI with life-threatening comorbidities. Okay, then they should be considered for surgery. So as we assess these patients, if their obesity starts when they were a child, more likely they already went through hyperplasia in their adipose tissue. So there has been increased the number of adipose adipocytes, fat cells in the system, making successful weight loss more challenging. We mentioned this before. We need to check for history of an eating disorder. We know eating disorder has a distorted body image. So some people may want to use the surgery to get skinny, beautifully skinny, or they think quick. So we really need to make sure the patients being considered for bariatric surgery do not have this condition. And again, the team of surgery will have some mental health professionals check their mental health status, right? We know there are certain conditions in addition to eating disorder. They, for lack of a better word, are obsessed of modifying their own body, whether it's a face or body or both. So we have to make sure this is not what they plan to do. We also need to check on their plan to exercise. We know that's part of a healthy lifestyle. And also their support system. As we'll see, to maintain a healthy lifestyle after the surgery, everybody needs a positive support system, not only for the, say, immediately post-operation care, that's important, but also how this person socialize, deal with their stress and pressure. All those could have an impact on their food intake and weight status. So we need to check all these. Also, during the nutrition assessment stage, RD will work with the patients. A lot of the work is to prepare them ready for the surgery. So there will be a lot of education and counseling, but we should ask the patients to verbalize quite some point. So all these are important information, and we cannot just give a handout to patient, okay, FYI, or read it yourself. No, we have to hear them paraphrase or verbalize this information. That's an indication, okay, they really get the messages. So, okay, what are these important points they need to verbalize? So they should know that while in the hospital, they can only be on liquid diet. And the first month after discharge, they will not be able to eat anything, even blended or pureed food. So that is to give the stapled area in the GI to heal. The resulting gastric pouch is about the size of a chicken egg, or half cup of food per meal. So that is even after the pouch is stretched to the capacity. So that means after eating, consuming about a half cup of food in volume, this person will feel full. So that's something to expect, really tiny amount. After the surgery, patients need to drink 3 cups of high protein liquid, and that is at the rate of 2 ounces per hour. This will be given to the patient by nurse. And once they resume oral intake, they cannot drink fluid with a meal, nor can they drink fluid within 30 minutes after meal. So really, they just cannot have water and the meal together. The reason is that the resulting gastric pouch is already very small. If we allow them to drink fluid together with a meal, really there won't be a lot of solid food entering the system. So they will have a very low intake on both energy and the nutrients. So we really want them to separate the two. And there are things that are off limits to avoid dumping syndrome. Remember, because certain surgeries bypass the pyloric sphincter, therefore, although tiny amount of food after surgery can be eaten, but they can all show up in the small intestine within a short period of time, triggering dumping syndrome. And so to avoid this condition, off limits are sweets and fatty food, right? And also to avoid dehydration, they shouldn't drink alcohol. They also need to verbalize that after surgery, when they're ready to eat, after they consume a half cup, they will feel full. And once they feel full, they should stop eating. They cannot keep adding one last bite every meal, because over time that will add on. Then the weight loss won't be as ideal, and the gastric pouch will be stretched, because it is a smooth muscle in the GI tract, so it can really stretch. And it is not good for them to drink carbonated drinks, because carbonated drinks in stomach will release CO2, which will expand the volume, so that will displace the limited food intake. So that's not good. 1 month after the surgery, patient can start eating soft meal plan. So soft, so we're talking about cooked vegetable, canned fruits, tender meat. So they may need to learn some new cooking skills to learn how to prepare meat, because they couldn't drink water with meat if the meat is too dry. So the moisture has to be built in the meat. So actually right now there are some cooking classes focusing on this, teaching post-bariatric patients how to cook a flavorful and tender meal for themselves. They need to know that they will be on nutrition supplement the rest of their lives. So this will become a religion. They have to take the pills every day as prescribed. Otherwise, due to the reconstructed GI, they can quickly develop severe nutrient deficiency. So commonly used supplements include liquid protein, especially shortly after the surgery. We mentioned this earlier, and also multivitamin and minerals. So they also need to put that into their daily routine. Same as say regular obese patients who are not critically ill, we use Mifflin-St. Jean equation to estimate energy requirement, the RMR. And we use 1.3 as an active factor for those who are sedentary. So majority of the patients who are getting ready for bariatric surgery due to their high BMI and comorbidities, they won't be physically active. So that's pretty much why we're using this. Before surgery, at the first visit, we need to educate patients on what to expect regarding food and fluid during the stay in hospital, as well as post-discharge. For example, we mentioned earlier they need to know and verbalize that in hospital they can only drink a liquid diet. And at this point, we should provide certain handouts, pureed bariatric surgery nutrition therapy. So we have these already available. So if your facility performs bariatric surgery, so this education material should be already there. So we need to give them the handout early, before surgery. And they may need to purchase the supplement they will need before the surgery, because once after surgery they need time to recover. Their mobility may be compromised for a while, so these things they need after surgery should be ready before they get into the surgery. And also supplement and physical activity, all these should be discussed even before the surgery. At the second visit before surgery, we need to talk about potential failure and why certain people's weight loss is not ideal even after the surgery. So number one reason is that certain people after surgery, they are not keeping the lifestyle and behavior changes. And again, there are individuals who think, okay, I had a surgery, so that's a license for me to live freely. That's not true. They still need to apply healthy lifestyle change and behavior changes to make sure to eat healthy and be active. And they drink liquid with meal. We mentioned that they're not supposed to drink liquid with meal or drink liquid within 30 minutes after meal. And they do not stop eating when they feel full. Right? They may feel, okay, I only had a half cup. Let me just add one bite. But 1 bite per meal. Next time there'll be another bite. Over time, the pouch will be stretched out. And also, they do not manage their emotional issues in a healthy way, which could be converted to, say, bad eating habits. Right? We should provide strategies to avoid overeating. And this is the time we could educate and counsel and work with the clients so that they can write down certain strategies themselves, because they know their life the best. So RDs as a facilitator may say teach them basic stuff, but ask them and encourage them to write down strategies that work best for their life and schedule. And we need to discuss and let them know that the first 2 weeks after surgery, they may need help during their recovery healing period. They may have some caregiver present, even living with them at home to provide care. So that's why at the beginning we need to assess their support network. Intervention during hospitalization, we need to monitor nausea or vomiting, so which is common side effects after surgery. We mentioned liquid protein for the first 2 days after surgery. So nursing staff are responsible for giving the patients these liquids. So RD don't need to worry about that. So nursing provide this to patients. So when patients are hospitalized, when we make a patient contact, we'll have to make some reinforcement on, say, knowledge, skill, as necessary. For example, we should really remind them, okay, you're not supposed to drink a liquid with a meal or within 30 minutes after a meal. And you shouldn't drink alcohol because that could lead to dehydration. And then based on what surgery this patient just received, we may want to discuss and tell them more about dumping syndrome and what foods to avoid in order to prevent this syndrome. For example, sweets and fatty food, we really shouldn't consume if they receive, say, Roux-en-Y surgery. And discharge eating plan. Remember, in hospital, they only drink a liquid, and the first months after discharge, they still go keep on that diet. Then, depending on the healing of the, say, stapled area, they may, after a few weeks, advance to a soft diet. By now, they already have the handouts you provided before surgery. Then, after discharge, we will need to follow up with the individual. So then we'll basically advance their eating plan based on their progression and their healing after discharge. So we need to monitor weight loss. Again, weight loss post-surgery is very impressive, so we need to document that, see if it is on the right target. And when patients return, they should bring a 3-day food record. Obviously, that means we need to tell them and teach them how to keep a food record. So they bring this food record to visit, but still we need to do a 24-hour recall in office, because with the facilitation by experienced RD, we may be able to get more information that can basically used either to assess or validate the information from a 3-day food record. And we need to assess adequacy of protein and intakes, because bariatric surgeries work by creating restriction on food intake and malabsorption. So yes, weight loss is the desired outcome, but we don't want them to have a malnutrition or nutrient deficiency. Right? So we really need to check if they are taking supplements as prescribed regularly, no skipping on any given day, and if they are doing physical activity as a part of a healthy lifestyle change. And then if everything is ready, they could advance to the next diet after 4 weeks.